breakout. And now we are ready for our second panel of this forum, Whatever Happened to Our 10-Year Capital Plan, that is going to be moderated by Bill Folks. Bill is Senior Vice President for the Cumming Corporation, where he's worked with many healthcare clients across the U.S. He's currently leading the firm's national work for Amazon and Microsoft. Bill has over 30 years of program management, development, and consulting experience, much of which is with the healthcare sector. He holds a degree in construction management and also an MBA, Master's in Business Administration. Bill's a returning moderator, and I have to say is one of the most knowledgeable people that I know in terms of the big picture of healthcare. So, Bill?
Thank you so much, Meredith, and welcome everybody to the session today. Day 2, panel discussion. What happened to my 10-year plan? I think we've got an amazing set of panelists for sure today. I would probably say that normally say they would knock your socks off, but I think we're all working from home, and for us,
we don't have socks on. We got flip-flops on, right?
We don't have socks on anyway. Exactly. So enough of my bad humor. Let's move right into introductions, and I'm going to let each one of the panelists talk a little bit about their background, about the current role in their organization, and maybe a fun fact if they want to do that as well. So let's start with Lindsley.
Good afternoon, Bill. Thank you very much. I'm Lindsley Withy. I'm a director at Guidehouse. My focus is around master facility planning and ambulatory network planning with experience of over 20 years with systems across the country. I started out working for Capgemini Ernst & Young, which was formerly Ernst & Young. Worked with Hammis Company, HCA, Health One, my own firm, and then most recently at Navigant, which is now Guidehouse, and undergrad at St. Louis University, as well as my MHA at SLU. And I am the regent for Colorado for the American College of Healthcare Executives, ACHE, for those of you that are familiar with that organization. And in Colorado, love working with many of the leaders throughout California in this role as well. I'm also a former advisory board member for the Cornell Institute for Healthy Futures, which is a very interesting organization, but the world's first academic center to combine hospitality and health policy management and design. So really excited to be here with you all today and appreciate the opportunity to visit with this great organization.
And welcome back, by the way, year 2, second year, right?
Yes, thank you.
Andrea?
Hi, everyone. Thank you, Bill and Lindsley. I'm Andrea Helft, and I'm the Director of Strategic Partnerships at One Medical. My role is to oversee the integration of One Medical with our health system partners and move them into performance and growth mode, and then work with them to identify strategic opportunities to grow the market. Prior to One Medical, I had a long career in strategy consulting for academic medical centers across the country. I went to Boulder for my undergraduate degree, and I have graduate degrees from Johns Hopkins and USC. Fun fact, I'm usually on the road visiting our health system partners, and I took advantage of COVID and being stuck at home to have sinus surgery and very major foot surgery. So I'm super, that's the blessing in disguise for me with COVID. So thanks so much. I'm really looking forward to the discussion today.
So you're coming out better after COVID than before, right?
Like, bionic is like, how I like it.
Bionic, Andrea.
Yeah.
Great.
And now you can breathe and walk at the same time.
It's amazing. I was sorry this wasn't sort of a nose sinus situation, but yeah, breathing is going to be amazing.
That's awesome. Dr. Holmes, please.
Hello, I'm Nicholas Holmes. I'm the Senior Vice President and Chief Operating Officer here at Rady Children's Hospital. I'm a pediatric urologist by clinical background. In 2011, I got an MBA in healthcare finance. And so one of my responsibilities in the organization is overseeing facilities. And so, which I actually is probably the thing I'm most passionate about at work, because if we don't have an environment that's conducive and healing, it's going to be really, really hard to be able to take care of patients and their families. So it's a really important part of our whole milieu and how we interact with our patients and families. So I'm a native of Washington, D.C., although I've lived in California longer than I've been living in Washington, D.C. So I went to Georgetown for undergraduate and medical school, and I got my MBA at the University of Tennessee at Knoxville. So a fun fact, I am absolutely enamored with Hawaiian culture and things of Hawaii. My background is downtown Kona in the bay there where the Ironman Triathlon starts. And so, so I am, even though I love playing ukulele, I'm not very good according to my family. So
Well, and
I
they're,
try my
That's
best,
awesome.
but I'm not very good. So
and they're reopening the island, so.
they are a little bit challenging how you're going to get there. So, you know, fortunately, people on the West Coast, it's going to be a little bit easier for us to get there. If you're in other places, it may not be so easy. So
Next time we're going to have you play the ukulele as the introduction music to.
maybe.
Maybe not. Practice.
Come on, can't we count on you?
Well, hey, you know, Lindsley actually mentioned her experience with ACHE, and so I'm going to kind of kick it off with a question for her. Actually, the most recent version of the ACHE Healthcare Management Journal has 2 articles in it related to this exact discussion. So, Lindsley, you want to give us a little bit of the kind of the state of what you're seeing change that has happened, you know, because of the last 8 or 9 months of what we've been going through?
Yeah, Bill, thank you. I mean, I know we have all been so much change in the way we work and live throughout all of our organizations. And I know that in talking and clients throughout the country, this has probably been about the most challenging time in anybody's professional work history that any of us have experienced. So we are just really thankful for those that have been on the front line, and we've worked with health systems across the country. At Guidehouse, we've worked with over 350 of the going through the pandemic and helping them with the restore and obtaining funding for some of the opportunities for improvement through COVID. And so we've seen a lot, but none of our health systems haven't had to anticipate or having to plan for surviving the pandemic. And so the recession and growing calls for racial equity, we've really fundamentally altered the economic and cultural landscape that will not only bring new pressures on operations, but on strategy and business development. So some of the, you know, in reading some recent stats of what's coming out of most recent months from the pandemic, TransUnion Healthcare Study just was recently published with some information around just from the different areas of the organization. So from an ED perspective, we're seeing that adult ED visits are down about 16% in August compared to pre-COVID levels. And peds, however, really still seeing a pretty dramatic shift of being 58%, largely due to patients avoiding the ED to transmission fears, but also the increased use of alternative treatment settings with telehealth, medical offices, and urgent care settings. But from the peds perspective, I think a lot of those contributing factors are due to the reduced activity levels that we're seeing with still schools being closed and sports being reduced. But pretty dramatic differences between what we're seeing between the adult and pediatric world from the ED perspective. From an inpatient perspective, we're seeing adult inpatient levels down still about 9% in August to pre-COVID levels. So really nice bounce than what they were. And then from a peds inpatient perspective, really pretty much back to normal, only down about 2%. And then from an outpatient perspective, essentially from an adult perspective, really seeing that pretty much back to normal, down just about 1%, but from peds still down about 23%. So some pretty dramatic differences between the two age groups, but really important to understand that as we're thinking about our strategies within the organizations. And I think as all of us have seen as just a dramatic shift of the telemedicine option and seeing best-in-class digital solutions that will now really be a necessity, not just a luxury that we've seen in the past. And so from our perspective, we're really seeing systems all across the board really trying to come up with a more comprehensive digital health strategy with an end-to-end approach, with really looking at the overarching strategy, looking at the digital front door. What does the virtual care delivery look like? How are you really marketing that outreach and communication as there's so many more competitors coming into the market around those strategies? Making sure that they've got robust data analytics around these strategies and understanding is there an opportunity for potentially strategic partnerships, and making sure that their staff is really trained on these organizational development changes, because they are drastic differences in the way that these systems have been operating in the past, and how quickly everybody came on board in making some of these dramatic shifts that they weren't able to just execute in the past. And this all really affects to the bottom line for organizations as they're thinking about their billing and reimbursement and payer connectivity. So the bottom line is very dramatically has been dramatically impacted. And then that kind of leads into the shift from employer-based insurance. So with dramatic layoffs that we're seeing, the pandemic is a painful reminder for us that health systems are so really think about their margins if driven by the commercial elective surgery. So that's really taken a hit on these systems as they struggle for the insured patients to cross-subsidize many of the lower paying providers with their high deductible health care plans. That's just not happening. So when we're seeing a lot of these dramatic impacts to the bottom line, this is really an area where we're seeing it has been deeply affected. That commercial enrollees will continue to decline with increases of unemployment, which hopefully will flatten out. But ultimately, this will have an impact in the deterioration of the payer mix for these facilities. And so they'll result in even a bigger push to look for low cost of care alternatives in these systems. I think we've seen through the news and maybe hopefully, I know many families have been impacted by just the long-term care strategies and hospital at home that we're seeing with loved ones. And so I think a lot of systems really trying to think through how can we maybe seek alternatives for the loved ones to provide more care at home. And that this is an ongoing strategy that many systems were facing, but I think a big push right now to really figure out how do we have better solutions for long-term care. And again, that kind of ties into a lot of the telehealth and different other options for providing care remotely. Obviously, a new big push on focus for preparedness in our system. So making sure that we've got infrastructure in place, supplies readily at hand, workforce flexibility, issues that in the past have been really more policies and procedures that we're just needing to make sure can be put into action. I think that would look deeply touches probably many of our participants is the real estate footprint and facility design, and how are we rethinking about that? I know Andrea is going to touch a little bit on this as well, but many hospital systems are really taking this as a time to reassess their footprint and services that are offered as they came offline, as they're putting them back online. Maybe is there a greater opportunity for some consolidation and some services that frankly just weren't really contributing to the bottom line? One example is wellness facilities and gyms that were really struggling in many markets initially, but this is really causing them to push, are we really going to reopen all those facilities? And maybe there's an opportunity to use them for something else. One example in a market was where they used this previous gym for employees to have their children have remote learning and that otherwise would not be able to come to work. And so they're repurposing those facilities, even if it's just temporarily through the pandemic. Another opportunity is really to truly a transition to the consumer-centric model. And with this, I think we all know this with the historical payer disruption we're seeing so many more entrance into the market, as Bill, as I'm sure you're seeing with Amazon, the Amazon Care Pill Pack coming in, with Alexa, so many more competitors in the market that, as we've known, have been really at the heels of our clients, just really breathing down the necks now. Walmart, being the U.S. largest employer, offers both payer and care services, including pharmacy and retail clinics. So those are going to be increasing competitors that I think are just not going to be going away. And as I touched on, just capital overarching will be more difficult to secure. So people are just needing to think very carefully about their investments going forward. And as they're thinking about those strategies, where many times we have the luxury of really thinking about long-term care strategies, they're having to think about what are those short-term and quick wins, really accentuating the focus on ambulatory telehealth and operational improvements versus some of the larger inpatient bed towers and larger developments that we may have been seeing in the past that may have even been mid-work, but are asking to really think about, is that really the right strategy at this point in time? And at the same time, many of those are being accelerated because they're seeing this as a great opportunity to build because of the cost opportunity here. So it really goes both ways, but I think systems are really taking a hard look at what is going to be the right strategy for them. And it could be, in many cases, it is acceleration with some of those capital plans. So
we'll talk a little bit more about that. Thanks for that, kind of giving us the overarching look at the market. I know you work all across the country with all those healthcare systems. Let's switch now to kind of some specific companies, and we'll hit with One Medical first, and then with Rady. Andrea, you heard kind of some of the statistics that Lindsley mentioned about the outpatient settings. Obviously with COVID, with CMS allowing some virtual visits, how is that impacting your clinic development and future plans?
Bill, that's such a good question. So we think a lot about being very available to people where they work, live, and play, and have partnerships with health systems in each region and build in a collaborative way. So it's desirable for us to build clinics, and in part because they serve as a billboard that we're in a new market. But we are, we, along with our partners, are being very thoughtful about, do we need a new clinic? And increasingly, we're hearing this from our partners. Do we need 10 clinics? What is the right number given this new environment? We have seen, and of course, we had a very robust digital offering for our members. And so when there became sort of parity in billing for a virtual visit versus an office visit, we were very well positioned to move forward with that solution. So we found, I think with everyone, that visits dropped way off when COVID hit. And then we sort of moved into a strong, in fact, all visits kind of dropped off. And then they moved directly, they ramped way up for virtual care, our visits. And now we're seeing more of a 40-60, 50-50 split between virtual and in-office visits. It will be interesting to see what happens as COVID, seems to be on the rise, and we're moving to some of the places where COVID is
spiking.
Yes, thanks. That's a really unfortunate and good word. So the upshot is that there is, I think there's sort of a tension, as Lindsley was describing, between, do we build more clinics? Do our partners support the new clinics? Does it make sense for us you know, it's a big capital outlay, and we're public, so we have to be answerable to our investors and to the market. So for now, I'm not seeing a lot of pressure down on the number of clinics we'll build per partner, but it's a part of the conversation in a way it wasn't before. Is that so?
Interesting.
Yeah.
Yeah. Well, great. Well, thank you so much for that. Dr. Holmes, I'm dying to ask you about the kind of the impacts on the capital plan kind of moving forward, because you have a large capital plan down there at Rady. I want to kind of take a step back and ask, you know, kind of how is, I know capital plan is in process. How have you done things different, or what things were changed from what you thought they might be over the last 8 months as you started to kind of implement some of the planning for that?
Yeah, that's a really great question, Bill. So thank you for that. So one of the big things is that we all know that, especially for acute care hospitals, there was a significant downturn, which is good because we always want people to be healthy. But unfortunately, our U.S. healthcare system is built upon illness, not wellness. And overall and patients, and so patient revenues across the board in every healthcare facilities were down. So as we're embarking on this next capital campaign in our capital master plan, is we really had to make sure that we built financial on-ramps and off-ramps throughout the project to make sure that we were in good stead. So we have a unique position in San Diego. We're the only children's hospital in San Diego County, so we have to be there for the community. So we view ourselves as utility that, when you flip the light switch, the lights are on. And so we have to always be there for kids no matter what. And so we had to figure out as we move forward with this, because we're, building a new acute care tower, as a result of some of the SB 1953 seismic requirements. So we need to make sure that this was a plan that was for the long term, that this was going to meet our needs, and as well as meet the community needs. So we had to look at through a little bit of a different lens. So
Yeah, you obviously had to have a lot of, and we're planning to have a lot of in-person meetings, user group meetings, things like that. How did that work out? Virtually, and what was that meeting your expectations, or did it? What was it? Just kind of didn't work. Tell us.
So actually, I was a little bit skeptical because we started this in the spring, right when the height of COVID hit. And so obviously everything had to be virtual. And so I think by now all of us have Zoomitis. So that is actually a clinical diagnosis. So, and unfortunately there's not a cure for it. So,
No cure.
So we, with our architectural partners, our development manager partners, we had over, I think it was 83 Zoom sessions from March until the end of August, with over 170 different physicians, nurses, family of advisory council members, hospital administrators, where we met and started to do the programming for our campus master plan. So, one of the things is I was incredibly surprised that it was really successful. And I think people learned how to communicate. I'm a very, as a surgeon, I'm a hands-on person, and I think the design process and programming process is a very hands-on experience. So we had to come up with unique ways of being able to make it a little bit more hands-on, as well as making sure communication was very clear about what decisions were being made, what selections were being made, and what directions were going. So I think it was incredibly successful. But it was definitely very challenging, because if you're all in the room together, you get those nonverbals. If people don't have their cameras on, you can't see them rolling their eyes when you make a suggestion about something. But it was a really great process, and so I think we learned a lot. And so, does all design have to be in person? Probably not, but I certainly think that that's a key component, because I think part of design is that human connection, right? Because we're actually building a facility that's actually for humans and making that human connection. So I think that that's really incredibly important. But so it's not easy, but it's doable. It requires a lot of work on all the key stakeholders.
Yeah.
Thank,
Bill.
come
Bill,
back and ask you a little bit more about the master plan and how that's and kind of if things have changed there. But Lindsley, I know you work all over the country. You're usually on, you're that consultant that's in the air more than on the ground. How has that impacted you have you been traveling as much, or how has the virtual nature of planning sessions for you been going?
Yeah, no, I've had 3 total trips since March, so lovely lifestyle change. However, we had a handful of projects that were getting kicked off right at the height of COVID, and one being getting a new facility getting ready to open in September 1, and starting in March at really looking at an operational and facility assessment to see, are they ready and prepared to open this facility. And from an operational perspective, what opportunities were there to change as they were moving into this facility? And this type of project, you're really thinking there's no way you can actually do this without being on site. And we were able to achieve a great successful outcome with not only this project, but many that completely 100% virtually. But as was just alluded, it requires a tremendous amount of communication in a completely different way than we've had to operate in the past. And really making sure that this becomes very much of a listening exercise than anything that we've ever seen before. So I think in many cases, it creates a communication line that people are really having to think differently how they are not only communicating with one another, but also the outcome was tremendously successful because there was the requirement for everybody to be very thoughtful and how that you are communicating with one another not only is different as was just described, but also I think a greater outcome probably than we would have had being on site, just because there was such the dynamic of really listening so hard to the stakeholders in a different way. So I think, it is possible. It is, in many cases, we thought it would not be optimal, but as we experience with many of our clients across the country, everybody has just done things tremendously in ways that they hadn't before, with the amount of dedication that I think everybody brings to the table and focus that this has required over the last few months to keep things going and moving very successfully. And I think in many ways, probably a better outcome than they would have otherwise, because we are thinking differently, and not for only the cases of a pandemic, but I think people understanding how imperative scenario planning and thinking about all the different potential outcomes that you may be facing really didn't necessarily take seriously maybe in the past. So we've experienced a lot of great success.
Yeah. Scott, it sounds like you might have a question before that. Let me just ask Andrea the same thing. Andrea, I think, it sounds like all the work's being done very effectively remotely. Has your organization had the same thing, or is it a little bit different for you?
No, Lindsley's comment around not traveling, really, it's such a gift. We have a significant new space in San Francisco, and because we're working very effectively remotely, we've launched several new programs. There is thought that we will, this may be the norm going forward. And that, of course, influences our real estate team thinking about where we should be locating clinics. If people aren't, I can't recall who said it before, but if people aren't going to care downtown, I think maybe that was you, Bill. Do we need another clinic downtown, or should we be placing them in more residential areas? Oh gosh, I just had a thought and it was fleeting.
I know you mentioned before that some of the actual locations where you have to go look at clinics that you're potentially going to be part of, that was really hard to do remotely, right?
Yes, thank you. That is exactly what I was trying to get to. So our real estate team really likes to be on the ground, looking at sites, seeing where they are relative to our partners' sites. That's super critical for us, for our business model. They want to make sure they're going to work in all ways. So we've when we couldn't get into sites, we tried sort of a virtual solution, like you might see when you're looking at a house. There might be sort of a virtual walkthrough, and our team was really disappointed it didn't work. So they've started now. They're on the road looking at sites, and are nervous that one of the challenges we were facing earlier is that we couldn't get inspectors in to give us the go-ahead to move forward. And we weren't able to get any sort of exceptions from the local governments. So
Yeah, jurisdictions.
Yeah, right. You can tell this isn't specifically in my wheelhouse, but so there's concern that will cause delays again, and we really have commitments to open the clinics. We've already worked with health systems on, citing and agreeing on size, all of the various components that we collaborate on with the clinic. So there's a lot of stress within the organization about how do we meet our 2021 goals for clinic development, and they're very aggressive, and it's really tied to our success in the market.
Gotcha. Okay, thanks. Scott, did you?
Sure. No, I think, with all of your contacts and resources, I think we need to come up with a vaccine for Zoomitis. I actually have a question. I do have a question for Andrea from the group. Yesterday, we had a panelist that was in agreement that we are seeing a move to home-based health as being a significant trend. If that's the case, how does One Medical model flex out into the home?
That is such a good question. So we're already in the home with our virtual care offering. We offer a variety of, we have visits that a member might schedule. We have just the call and get help immediately option. We're working with various enterprise group to care for their employees across the country, even where we don't have clinics, and that is really new and allows us to expand our footprint to where in places where we may never build, that wouldn't work for us with our target demographic. So this is really it's not something that is a huge concern for us, and in fact, we're finding opportunity in it. The other thing we're contemplating is we're really moving into COVID testing as one of our offerings, and there's discussion now about potential home kits being available, which would add our capacity. It would add a ton of capacity, and so we're quite excited about that. So this home care, just to recap, is where we've been and where we're going in a bigger way. Okay. Though if parity and billing changes, we'll have to revisit that. Yeah.
Do you see a percentage balance between in clinic and at home virtual?
Yeah. So if we're talking just about billable visits, not sort of the, hey, I may have pink eye, what do you think? If we're just talking about billable visits in clinic or virtually, we're starting to see parity. It depends on the market, but it's about 40-60. It's been about 40-60, 40% in clinic, 60% virtual. But in some markets like San Francisco, we're really that is shifting. People are happy, excited to come back in for care.
And do you think that as people become more comfortable in this environment, and if and when COVID does diminish, what's your expectation for their returning to in clinic? As opposed to becoming increasingly comfortable with a virtual visit. Any idea?
Well, we think there's going to be a continued emphasis on virtual. I think that that is our expectation, and actually our partners' expectation. So they are moving to initial appointments. If it can be virtual, it's virtual. And so that's another opportunity for us to partner with them and increase capacity. So I think the thinking broadly is that virtual care is here to stay in a big way, and that it's a great way to increase capacity. But what we often say internally is, oh gosh, where's our crystal ball? Because nobody really knows. But that's that's sort of the truism now within the organization.
Dr. Holmes, it's interesting. Andreas probably focus more as on the adult care. Does that work as well on the pediatric side? Because I would tend to think that you want to see the patients more. Is that the case, or am I?
No, that's interesting, because when we prior to COVID, we were probably, not that we didn't push a telehealth platform, but we were probably single digits in terms of our ambulatory visits. That was via telehealth. So COVID came, and then all of a sudden 60% of our visits were 60, and it went almost to 80% were actually via telehealth. And so now it's actually flipped back. It's actually 20% telehealth, but 80% in person. So one thing we have learned is all those things that we said we couldn't do via virtual visits, we were able to figure that out over the course of the past 6 months. So I would say that for a family, it may be a little bit different for adults, but I don't know how families are going to go back not having that tool available to them, right? So say, for instance, you have a visit with your endocrinologist. You've got to get your baby in the car with the stroller, your two other children as well. It takes you half an hour to get ready, right? You drive to the facility. It takes you 15 minutes to find a spot to park. You wait for 40 minutes to see the physician. You see the physician for 20 minutes. And that cycle repeats all over again. You realize you just spent 3 or 4 hours, and you've only spent less than 20 minutes with the physician. So whereas you have this appointment, you've got your cell phone, and you just click a button, and you're there and you're ready. So I think there's still going to be some component for that. I think that also is going to allow, especially for those people who live a significant miles away from the facility, right? As a tertiary and quaternary care center, there's a lot of specialty services we provide that it can't be provided in any other communities. And so if you can avoid having to get in your car or take public transportation, I think it's always going to be the way it is, especially for the pediatric market space.
Gotcha.
We have a question. Do you find that your virtual visits are easier to maintain on schedule? And is there a difference in length of time between the virtual visits and in-person visits?
So those, I think the time is comparable. I think the providers and the clinicians are spending just as much time. I think one of the things the advantage that they found is that really, and there's always, with everything that's been going on in the world, there's been a very big focus on the social determinants of health and the social environment that the kids are in. And you don't get that when you come into the office. Now you're able to see the home, see what's going on. You can ask questions, especially if there's any mental behavioral health issues. What's the space, workspace, or learning space that the kids have to do school? And so you're able to access a lot of information that you weren't able to access before with that. So one of the things I think we've been focusing on now is really making sure, as well as asking the families, is that do they perceive that the quality of the visit is the same, right? And because that's the most important thing for the patients and the families, to make sure that they think the quality of the visit is comparable. So far in our surveys, they have been, but we're really trying to validate that and put some really good processes around that. So
Interesting. Fascinating topic for sure. Let's switch all the way over to the fun and exciting finance side. Obviously, Dr. Holmes, with some of the hits to surgeries, etc., that's affected some of your finances. How so, and how is that kind of translated into what you're doing in your master plan?
So obviously, in the height of, well, actually, we're not out of COVID. I mean, even though it's, everyone says we're waiting for that second wave, we haven't completed the first wave yet. But in its highest moment so far, like everyone else, is that we stopped doing elective surgery to conserve resources just in case there was a really surge. And so there wasn't a surge in pediatrics. Resources came back available, and so we were able to continue with doing surgeries. So pediatrics is a little bit different because most surgeries aren't elective. So there's not a large amount of cosmetic surgeries. It's not just your anal colonoscopies like for adults and stuff. So things have gotten somewhat back to normal, but we really had to again focus on what our plan was and making sure that we weren't overbuilding. And so we had to go back and look at what our forecasts were. And so a lot of pediatric forecasts are based upon birth rates and obviously prevalence and incidence of diseases. But one of the key things is throughout this, kids unfortunately still got appendicitis. Kids unfortunately still got cancer. Unfortunately, babies are still born with congenital heart problems. And so really when we looked at it, is the tertiary and quaternary services really weren't going to change. And so that allowed us to actually move forward with the plan, but also really made us look at that as we create this new acute care tower. We have to make sure that it's acuity adaptable. So for the highest level of care as well as the lowest level of care that needs to be provided. So
it's a great, very interesting point, the way that you say that, and that isn't it, your planning didn't change too much because you knew there was going to be the needs there of the community that you serve. So Lindsley, how about you? I mean, we kind of hear across the country, Rady's an example where they didn't stop and they continued on because of the mission that they have. How about other locations kind of pausing, accelerating, canceling? I know one of the projects in your area in Denver, Sisters of Charity of Leavenworth, initially put their capital plan for a new replacement hospital on hold for 6 months. And then they came back and they said, okay, let's make up that 6 months and let's get it done as fast as possible. Probably looking at some of the similar needs that Dr. Holmes was talking about. What have you seen? Is there trends that you've seen across the country in terms of projects moving forward or projects stopping? Go ahead.
Yeah, no, it's market to market specific, obviously, but I would say every system that we have been working with, while there was definitely a pause from March through probably June, July on really pushing forward on facility infrastructure, it has come back fast and furious. And I think, Bill, what you just described is much what we're seeing, as they saw that as an opportunity to take a pause, make sure the planning was really in place, and that they had a lot of what Dr. Holmes just described as having strategies in place for really being flexible and the acuity adaptable, and making sure that they have the flexibility in their ICU and inpatient rooms. Really saw that as a time for planning to make sure all of what they were executing was really in place. And those systems that were going through master planning efforts that we're working with right now are seeing this as such a blessing that they have this now as an opportunity to really think about all of the strategy that went into their planning to date. So Where we just maybe wrapped up master plans, we are now, as it's going into more detailed planning, just going back and revalidating all of those projections to make sure that these elements that we just described and what people have experienced in the pandemic, truly needing that flexibility, was really taken into consideration across, not only on the inpatient side, but which typically is planned for from the inpatient side, but a lot from the outpatient side as well, is making sure that they really have that flexibility in place. So many places have seen this as a blessing, as then they're really trying to accelerate the planning process and move forward with, as we just described, a tremendous opportunity to build if you can, because of the costs right now. So,
Yeah, and design. Let's not forget design. I mean, I think
absolutely design. Absolutely. And this is, from the design standpoint, this is just a tremendous opportunity, as we're partnering with architects, really just making sure that that's been very thoughtfully designed, and tremendous opportunity from the design standpoint to make sure that everything's really had a second look, given the latest pandemic issues. And just to touch on, Bill, from the budgeting perspective, I think what we're also seeing from systems is the need for really having the dynamic budgeting and not looking things just at an annual perspective, but reassessing that on a monthly basis. And so we're seeing that is really something that's really important, to have those rolling forecasts that they're looking at.
Is this a time for
forecast? Kind of looks at the the capital expenditures versus the revenue that's coming on a monthly basis now. Is that right?
Right.
Wow.
Yep.
Could we ask quickly about the growth of, given the growth of telehealth, anything that you can add about what the infrastructural changes will be, in the physical environment, or else or even operationally, that you've come across, and what kinds of infrastructure supports will be required? Although I do think we'll touch on that tomorrow during our panel, but if you have any short answers to that.
Yeah, no, from, telehealth perspective, what Andrea alluded to as well, I think we're really seeing this as an opportunity for people to look at their footprint. As I think everybody has mentioned how much of the visits have been able to translate to telehealth, but we're not seeing in many cases, as telehealth tends to be incremental volume in many cases. So it's not always, we are not saying that it's a substitute one for one, but it's more incremental. And so I think being very careful about what the long-term effects are going to be from telehealth, from a facility need perspective, and versus how do we make sure that we can incorporate it more seamlessly in each of our facilities, as well as the overall delivery of care. So we're not seeing that necessarily necessitating a tremendous amount of reduction in space, but really more, as we've all been talking about, that flexibility, because there are other needs for some of these facilities that they're needing with COVID testing, and having to have more isolated patient space and all of those pieces. It's not necessarily a reduction in space, but making sure it's flexible to use a little bit differently throughout the system and network.
Great. Another question for you all. With the medical research and customized medicine programs going on, are you seeing more goals for the development of translational medical facilities?
That One Medical does not touch on those.
Okay.
Short and sweet answer there. Dr. Holmes, from Rady's perspective?
Well, so we do have so we're fortunate to have our Rady Children's Institute of Genomic Medicine, due to a wonderful gift from our benefactors, the Rady family, to how we incorporate genomic medicine into how we deliver care. And so as we move forward with our new acute care tower. We are trying to incorporate the elements, whether it's translational medicine research and clinical research. How do we incorporate those elements into the design process? So we wouldn't necessarily have a separate facility per se, but how do we incorporate the elements of that within what we're doing presently? So.
Here's another one of interest. How does this healthcare model that we're talking about, telemed, etc., virtual care, flex into rural areas and underserved areas, including Native American communities, which are terribly underserved?
You know, I'm actually going to make a comment on that because I've done a lot of work on the Native American side with tribes and with IHS, and I think that the comment is exactly right. They are tremendously underserved. They're underfunded. Their funding goes up somewhere in the neighborhood of 1% to 2% a year. Compounded over about the last 20 years. And we all know what real healthcare has been costing, right? And so I think, the opportunity to have telehealth help with that is amazing. I mean, it's transformative. And unfortunately, that telemedicine opportunity also comes at a cost that we just need to be able to get IHS and to get that funded to be able to have those things happen. It is such a remote, whether it's Native Americans or Alaska Natives, they are so disparate. As a matter of fact, one of the studies that I worked on in Alaska was the largest cost for healthcare over the course of the year was transportation, because they actually had to fly a physician or fly the patient from the remote locations where they were at. And so I think the idea that can really kind of help that very needy population is out there. We just need to have some way to be able to implement that across the board right now.
Would One Medical be, for example, reaching out to those populations?
I think in the future we would. Right now, our medical model doesn't support taking Medicare, and so it wouldn't work. And the way it wouldn't work for our partners. They're the ones who really dictate what kind of insurance we can take.
It goes back to what David Johnson said after he complimented One Medical up one side and down the other. He said it depends on you got to follow the money a little bit to how that works out. And the fact that we've promised to serve the Native Americans, and I'll get on my soapbox a little bit, and I've done a poor job of that. In my opinion, we should just incorporate that into a model that we already have to allow innovators like One Medical and somebody earlier mentioned PillPack, to allow those types of firms to be able to help start to serve those populations. If you can't, if the money restrictions don't allow those things to happen, the innovators aren't going to be able to bring that innovation out to those populations.
We have some more questions. One is about acuity adaptable patient rooms. During the design process, a lot of times these are found to be prohibited because of the additional costs that are incurred. Do you see the need to sort of overrule the additional cost in terms of a cost-benefit analysis and maybe see that those will be actually implemented more?
I think Dr. Holmes just mentioned that in his tower. Do you want to talk a little bit more about that? And
so we have a unique
adaptable. Are you?
Yeah, so we have a unique situation. Obviously, for a pediatric patient being the only children's hospital in San Diego, we have to make sure, especially during our viral season. So we have a very cyclical census. So between November and March is normally our peak census throughout the year. And so we'll get a variable degree of patient illness, right? And so oftentimes our ICUs are incredibly full and we have to create overflow ICUs. So for a pediatric healthcare facility, it is the opportunity costs are well worth it, because there's a lot of shuffling of patients that have to happen as a result, and can become a patient safety and a quality issue. So maybe very different. I haven't been in the adult space for over 15 years, so maybe very different in the adult space, but it does allow a lot of great flexibility for us in the pediatric space.
Thank you. Lindsley, you want to comment on the adult?
As far as acuity adaptable,
Yeah. What, I mean, are you still seeing, I mean, it's been around for what, 10 years or so. And at one point it was all, let's make them all exactly the same. And then of course the money pressure came in that they were so much more expensive. What are you seeing?
yeah, no, we are absolutely I think, and part of what I was mentioning previously, and really looking at just making sure and the more detailed planning from a design standpoint as well, that from the ICUs that we've got those acuity adaptable models to be able to flex from med surge to ICU beds. We're seeing that from both an adult and a pediatric perspective to continue to have that flexibility. But when I say continue, we really have pushed to have that in the past, in the last several years. But I think now when it came to push to shove, when, with looking at budgets, I think people are much more serious about making sure that is a consideration that moves forward versus maybe got, was ultimately at the end of the day when the budgets were too constrained, that maybe that wasn't a top consideration. And I think our it's an element that needs to be absolutely embedded in a top priority to have that ICU capacity.
Right. Yeah, totally creating, negative pressure zones within the hospital or rooms themselves. That adaptability based on what we've gone through the pandemic has really risen to say, hey, this isn't something we can just cut out of, as a cost element out of our project, because we may have this need. And when you look at it in the bigger picture, it's far more valuable to include it than it is to exclude it and try and modify later on.
Exactly.
Yeah, absolutely.
Here's another question for you regarding mental health, behavioral health. COVID obviously has increased behavioral health requirements and is anticipated to continue to do so. So have you thus far seen significant spikes in your behavioral health visits? And along with that, I'd also like to ask if you have an idea of, say, what percent, especially for One Medical or for virtual, what percent of these visits would you say are behavioral health of your virtual visits? So first the spike and then a percentage, what you've seen.
We have definitely seen a spike, and we're trying to address it in a couple of ways. And for our members, we're offering group visits and emphasizing the fact that our providers are trained in behavioral health. But we're struggling if a member needs to be referred to a health system with access. Many of our partners they're at capacity, and we know it's a nationwide problem. So, but this is on my list of things to discuss every day. Not only to work with our partners to figure out how to increase capacity, but to work internally to identify options to care for these members. As far as the, and I also want to add that we actually anecdotally, I've seen more of the providers with whom I work, my colleagues, talk about their stress and how it's gone up. So, but as far as percentage of visits, I don't have a sense for that overall. It just has gone up. We share data monthly with our partners, and you can see that it's behavioral health referrals anyway have gone up.
All right, one last question for all four of you. If the objective is to lower the cost of healthcare, where will the money come from to expand, bill, and advance that care? I mean, Dr. Holmes, you've got great benefactors in the Rady family and other, great donors. But this is a real challenge for lots of systems and facilities as to how do you deal with this? You're cutting back on the cost of care, and at the same time, the cost of expanding and growing is increasing. Yes. How do you address that? How do you address those challenges?
Well, our one way we're addressing it is through our health system partners. So with integrated care, we're reducing double testing. We're creating a more seamless experience for our members and improving outcomes. That's the goal of being tightly integrated with our partners. And we have shown that that the model is able to reduce to pull out the total cost of reduce the total cost of care by, and I can't remember exactly. An older study said 11%, and a newer study was right around there. It's in JAMA, so something to look up. And I'm sorry I don't have it top of mind.
It's the concept, and those guiding forces that are really helpful.
Yeah, if we have the answer, that's the $1 billion answer, right, to the problem. So I think integration is the way to probably just solve it, and making sure that there's alignment across specialist primary care and large health systems. So to make it in a nutshell. So.
Lindsley?
Yeah, I mean, what we're really working closely with clients across the country is really aggressive cost management and opportunities to be looking really at themselves as an organization from an operational perspective, but really what are those fixed costs? And ultimately getting to a point where there are no fixed costs. Everything should be a variable cost at this point in time, and everything's on the table. And how are you looking at not only your clinical staffing, but support staffing, supplies and pharmaceuticals across the entire organization, because there are so many demands right now, and where's the money coming from? And we're working with a lot of systems and COVID relief funding. And so there's a lot of creative ways to be thinking about how can we use some of these CARES money, money that's coming from the government as you're thinking about the impact of COVID. As you're doing projects, many times you can get that funding for some of these projects that you were, as a organization, was a strategy, but is absolutely directly impacted by COVID. So we're working with a lot of systems and understanding what are those priorities and where can you get some relief from some of this funding to help support some of those initiatives as well. So I think it's really important for systems to understand that they're not there alone, and that there is support out there for many of what would be an initiative they're trying to do anyway. It's directly impacted by COVID, and that there are relief dollars. So thing to understand.
Great.
Bill, wrap it up, and then we'll hand it off to Meredith to do our next.
Yeah, I will. Thank you so much. First of all, thanks to the panelists. I so appreciate your time and discussion with us. I think next year this same panel is going to come back and have a cure to Zoomitis and to be able to explain the run-on toilet paper that we have. Thanks again to everybody, and I'll turn it back over.
Thank you very much, you guys.
Meredith.
Really appreciate it. Thank you. Great panel.
Really fun.
Okay. Bye, Bill. Thank you. So we are now, for the next few minutes before our end, going to go into one of the most important things that this group does, which is talk about and announce our winners of the scholarship award. I want to say quickly that this award, this whole program began several years ago, and Trisha Clark, who is on the screen, was actually actually had the brainchild to start this. Brainchild? No, not a brainchild. But anyway, it was her thought.
Great idea.
The great idea. And so, and it became something that is actually becoming national. It is now national with other chapters. And we are now going to announce who these lucky winners are. And it makes us all feel, I think, great about the fact that we can positively impact some of these architectural students' lives. So here's Trisha. Trisha Clark is one of our planning committee members and also vice president of Canon Design. Thank you, Trish.
Thank you, Meredith and Scott. Appreciate the opportunity to work with you guys on this committee. It's been a huge amount of fun the past few years. This year, we had a really great turnout of applicants for our scholarship, and we'll talk about that a little bit more. But I just want to let you know that this year, our committee got together and we decided to name this scholarship the Robert Kane Healthcare Design Educational Scholarship in recognition of his dedication to working with the students at Cal Poly Pomona and to Hofu Wu at Cal Poly Pomona in developing the program for healthcare architecture within the existing architecture program. And so because of our sponsorship has been so wonderful, we exceeded our financial goals the other year. And we said, since we've exceeded our goals, let's give back to our community. And so we were able to develop a scholarship, and we got approval from the AIA to utilize some of our funding for scholarships and have continued the program moving forward. So with the forces that continually shift and improve healthcare delivery, this scholarship opportunity supports the importance of developing the next generation of architects to continue reinventing the design and delivery needs of tomorrow's healthcare facilities. I'd like to share with you a letter that we received from one of our scholarship recipients last year, and it'll give you a little flavor of the impact that this has on them.
And goosebumps.
She writes, I am incredibly grateful to have been chosen as a recipient of the AIA California Healthcare Facilities Forum Scholarship. As a young girl, I never knew what I wanted when I grew up. My interest in architecture began at Consum's River College in Sacramento. I took an entry-level course out of the curiosity and was introduced to the profession by some of the most incredible and passionate professors I've ever met. The application of both technical skills and creativity made it challenging and engaging, and I absolutely fell in love with it. Looking back to the beginning, taking a chance and enrolling in my first architectural class, how many of you can remember that? Changing the trajectory of my life. I wanted to take some time to tell you a little bit about me so you can understand how unbelievable thankful I am to receive this scholarship. I'm currently studying at Cal Poly Pomona. My ultimate dream would be to open my own architectural firm and one day concentrate on regenerative design. Thanks to your financial support, I feel a certain sense of freedom in exploring extracurricular activities and becoming more involved in the community at my school. This semester, I took a position at Cal Poly Pomona chapter as American Institute of Architects students, my biggest semester goal this year. Next year, I would like to run for the position of president so that I can continue to be a leader amongst my peers and enable them to do the same. This wouldn't be possible for me without the financial support of your scholarship, so I'm deeply grateful for the opportunities you have allowed me to take. I can't say thank you enough to your support in the development of students like me and pursuing my career in building this industry. Because of your generosity, I will be able to purchase my tuition, books, and other expenses this coming semester and take advantage of new opportunities to engage in my education. AIA generosity will support this achievement. When I think about the future looks like, I hope one day I can have the opportunity to pay it forward to a student like myself, same way you did for me. Thank you for investing in my future for your generosity truly makes a difference. And this was signed by Kristen Lawrence, Cal Poly Pomona. So this is the kind of impact scholarships can have in helping give direction to students who really want to advance in the healthcare architecture program. So I thank you to our sponsors who give us the opportunity to give out these scholarships. Our committee this year, John Caskey, John Battle from Canon Design, Gia Chang from Cedar Sinai, and Gary Goldberg, all contributed in evaluating these applications. We had more than twice as many applications as we did last year, and it was very difficult competition. So with that ado, I'd like to announce our winners this year. Andrea Lansing from Cal Poly Pomona is achieving her Bachelor's of Architecture in Urban Design. Anticipated graduation is 2021. Priya, and I'm going to say, I apologize, I'm going to mispronounce your name. Sathya Rana is at Cal State Berkeley, College of Environmental Design. She is getting her PhD in architectural building science. She's involved in a lot of research, and she's very invested in the research side of this business, which is wonderful. And her anticipated degree is 2022. And Victoria Dam from the University of Southern California, Masters of Architecture, anticipated graduation is 2021, and her Masters of Building Science anticipated graduating in 2022. Congratulations to all these recipients. Please note that there is an opportunity on our website if you'd like to make a personal contribution to the scholarship. We would appreciate it. Thank you very much. And these scholarship attendees, as well as other students, I think we have 20 students attending from Cal Poly Pomona. So feel free to seek them out on the chat room and congratulate them and seek them out as potential hires when they graduate. Thank you.
Thank you, Tricia. And for all of you, if you can still access if you look on your chat, on your chat button, you'll see that there are some thank yous from our recipients. And I am sorry that this year we can't see you guys live and have you stand up and hear us applaud for you, but we applaud. We're all applauding in our minds and in our hearts. So that was really moving. And so anyway, thank you. Thank you. Thank you, Trish, for making this happen. Thank you to everybody that's participated in the scholarship and to everybody, of course, that's contributed. It makes and made differences in people's lives, as you can tell. That's it for today.
That's it.
But
Absolutely.
you have more tomorrow. We hope you'll be able to come back. If you can't, again, this is recorded, but we do want to tell you that tomorrow our speaker is back by popular demand, Ron Galloway, who was here last year, who undoubtedly will have you probably in stitches and probably have your eyes bugging because he's so interesting. And we will have a fascinating panel that will talk more about technologies and will take you a bit out into the future. So thank you, everybody. Have a good day. Have a good afternoon, and we'll see you tomorrow.